Our next speaker, Dr. Ray Matthews, is a professor of clinical medicine, and he is our chief of cardiovascular medicine here at USC, Keck USC. He brings 20 years of experience in high-level tertiary interventional cardiology to our institution, and he is a leader in the advancement of percutaneous treatment of peripheral vascular disease, and he's my cardiologist. So I introduce you to Dr. Ray Matthews.
So that means I'm really good at difficult patients. So it's my pleasure to come talk to this group today. We're going to focus on some new techniques in cardiovascular medicine that dovetail into a bloodless program. What we try to do as interventional cardiologists is find alternatives for larger surgical procedures that can be applied to a wider range of patients, safer, at lower risk, and it turns out, just sort of coincidentally, with no need for blood products. So it all kind of works together here. So our goals are very closely aligned to this group. So cardiovascular interventions are becoming options, and really we could have an entire weekend symposium on all the different kinds of procedures that we perform. But I'm just going to pick out maybe 3 here so I can give you an idea of how this works and how this evolved and how we can maybe help with some of your patients or even help you care for your patients in your own institutions. So cardiac surgery can be done in a bloodless environment, but it's difficult, it's challenging. But the evolution of high-risk PCI on those patients that otherwise would get bypass surgery has really been a game changer for us. Surgical aortic valve replacement has its challenges with the need for cardiopulmonary bypass, but with the ability to now put these valves in without a surgical incision is really kind of a game changer. And now we're moving on to the next valve. We're actually doing interventions that are very creative, very, very limited incisions required to approach the mitral valve as well. So let's take a little journey down through this. So let's start with a case. Cases are always more interesting. So here's a patient, a 73-year-old male who's transferred for bypass surgery. And he has an ejection fraction of 15%, and he has a left main lesion. So this naturally, with left main disease, we're thinking more about bypass surgery than we are about coronary interventions. And the idea that when you do a coronary intervention, you would have to occlude the left main for a few seconds is a daunting task. So how do we actually get that done? How can we do something for this guy that is a good procedure and kind of not put him through a surgery? So it turns out that the key to this is supporting the patient's weak ventricle while we do our coronary intervention. And we do this with a little, I'm going to pass this around for you. I actually have a little visual aid here. So this is a small little pump. It's about 3 millimeters in diameter, and it can pump 2.5 liters per minute. Aspirates from the left ventricle and injects into the ascending aorta. And that is the shaft of it actually comes out the femoral artery, and it's cut off there on your visual aid. But it allows us to actually support the patient for a short period of time while we do our coronary intervention. Provides us to support the arterial blood pressure, to actually inject into the ascending aorta, but also to aspirate from the left ventricle to reduce the pressures inside the ventricle, to increase the coronary blood flow by lowering those pressures in the ventricle. And so all those things help us get through the procedure. So this is how this looks. So we start off by making sure that our lower extremity vasculature is adequate to accept the device. And here we see our device is sitting in the left ventricle. Here in the ascending aorta, aspirating here, injecting here. It sits there calmly, it's out of the way. And you can see we're injecting contrast material. There's just a little pinhole of flow into that left coronary artery. So this allows us to inflate a balloon and a stent and repair that to now a wide open artery there. So you can see at the end of that catheter there. So this is all done very calmly, coolly, without any fuss or muss. And at the end, you can see that these are pretty large bore catheters, but we've developed specialized percutaneous techniques. Here's an angiogram after we take that catheter out at the end of the procedure. No bleeding, no blood loss, because we have developed techniques to suture close these from the outside in. And so that's a very effective way to avoid what is typically a concern when we use large bore catheters. Good, so it all looks fine at the end. So how about a second case? So here's a little bit more similar kind of case. This is a 93-year-old female who had lots of angina, was admitted to our hospital, and we tried to manage her medically because of her advanced age, but we really weren't successful. Finally, we had to do a coronary angiogram, and we found what we really didn't want to find. We found very serious disease, which showed a very calcified distal left main bifurcation lesion. Typically, again, a surgical intervention, but in an elderly woman who has a reduced ejection fraction, really a pretty high-risk surgery. So you know that the patient is very high risk when you refer them to your surgeon and they suggest stenting, which is not common. So this is what this looks like for this lady. So again, we start with our femoral angiogram to make sure that our catheter access is adequate. And here it doesn't take a cardiologist to see that the entire heart circulation is going through these two little pinholes here. And if you're an experienced cardiologist, you would see that there's a lot of calcium there too. So not only do we have to expand and place stents in there, but we have to actually drill that calcium out or the whole thing's not going to work. So drilling in the left main causes a lot of adverse problems with the patient, so we need to support them while we do this. So this catheter technique allows us to support them. Now, obviously, this would be a very straightforward surgical operation were it not for the bad ventricle and the 93 years of age. So this allows us to take a patient who otherwise would be a reasonable surgical candidate or reasonable surgical operation and offer them a technique. I'm just going to go through these other pictures here as we gradually put wires down there and eventually put stents in there. Now you can see that those blockages are completely resolved here. So this is a way that we can actually perform the surgery from the inside out. So this 93-year-old lady lived an additional 2 years, saw me every 6 months, and enjoyed her grandchildren and great-grandchildren, and had really no change in her serum hematocrit before and after the procedure because there's no need for blood products here. And again, very carefully managing the groin issues in that regard. So that's coronary artery disease. So that's what we can do. We can take on things that are difficult for our surgery colleagues to take on and attractive to your patient care group of interest because they don't involve transfusions. We have very specialized techniques to manage the vascular access issues. So let's shift gears here a little bit, move on to the aortic valve. So aortic stenosis has become a problem in our aging society. So you can see that a large percentage of patients greater than 65, almost a third, will have some degree of disease of their aortic valve. So as we live longer, we're going to see more of these patients. And the problem is that these patients, by definition, are old and difficult and high-risk surgical problems. And the concept of replacing the aortic valve is a good one. There are literally decades of experience replacing the aortic valve. It works, it improves survival, but it has to be done surgically. There's no alternative medical therapy for dissolving the calcium or anything of the like. So this is the problem. It's a good procedure, surgical aortic valve replacement, but it's a big deal, and the patients are old. It's difficult to get them through this. And of course, there's significant risk for the need of blood products in this age group. So one of the things that has happened is someone had the bright idea, why can't we replace this valve with a catheter technique? And so the way that gets done is a new valve is actually implanted, my second visual aid, a new valve is actually implanted over the existing valve. So we use that calcium to actually help anchor the new valve in place. So we open the old valve like a door, put the new valve inside it, expand it into place, and it's held there by the old calcified valve. And we can do this without stopping the heart, so we don't have a need for cardiopulmonary bypass. And there's specialized materials, so here's what this looks like. There's no valve sewn into this, but I can take this and squeeze it in my hand like this and deform it into any shape I want, and it comes back to normal. So there's specialized engineering techniques that help make all this possible. The valves come in different sizes. And there we go. So, and the most challenging thing of this lecture is not putting the valve in, but advancing the slides, turns out. So here's what it looks like in the aorta here. We have a small catheter to mark our position of the aortic valve. We actually pace the heart. If we pace the heart really fast while we're implanting the valve, we can transiently reduce the cardiac output to 0 so that the valve won't move as it's being deployed. The valve comes out of a self-expanding sheet here. You can see it begins to flower and makes a shape like this. And here the valve, we're still hanging on to the valve, but the valve's working, and then we finally let this go. So I'm going to take you through some movies of how this works. So we'll start by advancing the valve. These have gotten very low profile over the years. You'll see our valve in a collapse shape going through the pelvic vessels there. So these are now down to about 5 millimeters. So even small little ladies, a 5 millimeter shaft can actually be advanced through there. So you can see that we carefully do that. Careful not to damage the vessels on the way up. So now we get our catheter in place. We begin to withdraw our sheath. Here's our pacemaker pacing the heart, wire in the ventricle. You see the valve begins to flower and expand there, right? So the heart's actively beating. There's no blood circulating outside the body. It's all in the body where it belongs. And we deploy that valve very gradually, very slowly. We have about a 2 to 4 millimeter area where we get it just right. And if we don't get it just right, it turns out the latest iteration of this valve can be recaptured and repositioned. So we get a second chance, which is really nice for us too. So once we get the valve where we think we want it, we can do a little contrast injection here, make sure that it's sitting right at the edge of the valve like we want it. We're happy with that. And then we can let it go. So we keep expanding it. You can see it pops into position, just like that one we're passing around the table for you to squeeze. And I need those back, by the way. I have a patient tomorrow. And honestly, there's a lot of preparation and planning that goes into these treatments, but in the time it took for me to show you that video, it doesn't take one bit longer to put this valve in if you have a lot of experience. So really, it's just as quick as it looks. And then we assess that with an angiogram, and that's our patient. So the aftercare for such a patient is many of these can be done under conscious sedation, don't require general anesthesia for a variety of reasons goes into which technique we choose. Our typical length of stay is 48 hours, sometimes just 1 day, sometimes an extra day, but we average about 2 nights, so that's what we tell people. So it's been proven in 3 risk groups in a randomized clinical trial in extreme risk, high risk, and intermediate risk groups, and it's currently being studied in usual or low risk groups. So people like you who would be low risk patients, it's now that the clinical trial is underway. And it's been proven to be equivalent, and actually in 2 of these studies, better than surgery. So, and remember, we started out by not trying to beat surgery, but just provide an alternative that's less invasive. So we think that we've really had a lot of success there. No scars, groin puncture only. So now we say, next valve. We got that one. The aortic valve, we got some good answers for, so we're on to the next valve. So it turns out that the problem of mitral regurgitation or leakage of the mitral valve is a very big one. About 250,000 people in the United States every year suffer from some degree of mitral regurgitation. And when the mitral regurgitation becomes severe, your mortality is strikingly severe as well. So it turns out that this is also a disease of people who are mostly elderly. And although this concept of an open surgical mitral repair, again, very, very good procedure, there are many patients who are at high risk for that procedure, primarily due to age and comorbid states. So we're searching for something that we could offer, we could do remotely from a catheter that would involve only a groin puncture. So you see what our theme is. Our theme is not complicated. We want to do what the surgeons do, only we want to do it through small, minimal access. So this is what another smart guy was paying attention to what the surgeons were doing. And there was a South American surgeon named Alfieri who did a very simple open surgical procedure, took the two ends of the mitral valve and just made a little bow tie out of them. So that tightened up the valve enough that it stopped leaking, and his name was Alfieri, so it was an Alfieri stitch. Very quick, very simple, but again, had to go on cardiopulmonary bypass to accomplish that. And so it was still a big surgery with attendant risk of blood draw. So somebody said, wonder if we could do that with a catheter. Wow, wouldn't that be great? So they tried to do it with a stitch, and actually the animal work failed. The stitches kind of pulled through, so they developed this thing that's like a little clip. So that it's a stainless steel clip that's covered with Dacron material. Sorry, I don't have one of those, no visual aid there. But it actually is put into place, and under echocardiographic imaging, you wait until these leaflets kind of come down onto the valve leaflets come down onto the clip, and then you drop these little fishhook-like things that are called grippers, and they grip the leaflets, and then you tighten the clip together. So if you've ever been to the carnival, where you're trying to get that little stuffed animal with that little crane thing down there, it's a little like that. Half fishing and half carnival thing. So we have an elaborate device that sits on the table next to the patient, goes in the patient here, and it has these elaborate set of controls that let us move the tip wherever we want it, open and close it. We don't get our clip in exactly the right place, we can move it to a new place. Or we can put 2 clips in, or 3 clips in, or whatever we need to do. And the other thing that's really nice is if it doesn't work out, which is a small number of cases it doesn't, we've done nothing to remove the surgical option here. The surgeon can still go in and replace that valve, take our clips out. So that option is still present. So this is a good thing, right? So here's what it looks like. Here's what it looks like if you surgically tie these two together, and here's what it looks like if we put a clip in there. So it makes that little bow tie-like appearance to the mitral valve, and you can see that they're equivalent in animal experiments for sure. So how the clinical trials come out, where this is the device group. So this is patients with 3 to 4 plus mitral regurgitation, and about 80% of them we were able to improve that by 1 or 2 grades, which is really good. Sometimes that's all you need to do. The control group here is actually surgery, and you can see that we're not as good as surgery, because the surgeon has a tremendous advantage. He's like looking directly at the valve, sewing right on it, and see it, and we're like, it's a little like a mechanic sort of putting the hood up about 4 inches, turning his eyes like this and trying to fix your car like this. So, as opposed to the mechanic who's opening the hood. So, of course, the surgery is going to be better, but what an option for the patients who are at high risk for surgery. So we think that this is a major advance as well. So this is performed with general anesthesia, a single venous puncture, not even an arterial puncture. So the risk of blood loss even lower. 24 hours, they go home the next day. The absolute next day. We keep them overnight. We probably don't need to keep them overnight. The downside of this is it's very, very technical. Extremely difficult. You have to think in 3 dimensions. It requires 2 interventional cardiologists to do this. There's a significant learning curve, knowing exactly how to do this, how to get in and out of there. So this is not for the faint of heart. Not great acceptance in community hospitals for those last 2 things. Highly technical, significant learning curve. We have a 3-year experience in that. So sometimes if the clip doesn't work very well, now we have the ability to actually replace the mitral valve, which is a big deal because the mitral valve is different. It's larger, it's floppy, it doesn't have a rigid annulus like the aortic valve, so our plan to replace the mitral valve has to be very, very complicated, and it's a much more difficult task to accomplish. But I'm going to show you how we did that too. So again, mitral regurgitation is a big problem, and a equally big problem is how do we get a large bioprosthesis in there? So it's actually two bioprostheses inside the other. So the actual functioning valve is a rigid structure like the valve that the surgeon would sew into place. So it looks exactly like the one that you would get during surgery. But we have to have this external ring that is flexible and deformable to sort of hold this bioprosthesis in place. And it's got a bunch of barbs or hooks on it that allow it to attach to the native mitral valve to go into position. So this is what it looks like in animal studies at 90 days. You can see here's from the bottom of the valve from the ventricular side and from the atrial side as well. And you can see that it seals in nicely in a relatively short period of time. Easier than advancing the slide. And so the current iteration is a 28 French sheath, which is about 8 millimeters, 7-8 millimeters. So this has to be put in through a small incision in the left chest to the apex of the left ventricle. But we're going to do this on a beating heart. So we're not going to do cardiopulmonary bypass. We're just doing a small incision there. So they'll come out with a little chest tube. So that goes through the apex, retrograde across the mitral valve, slowly expand it into place. And you've got the drill now, so you know I'm going to show you a video of this. So here we go. So this is fourth patient in the world that was implanted. This is not our patient. So you can see this mitral valve. You can see that it prolapses into the left atrium, and that turquoise stuff is not supposed to be there. So the turquoise is leakage of that mitral valve. So now there's a catheter across that mitral valve. You'll see that device begin to flower into the left atrium here as it's slowly expanded. Again, the heart's beating. We're doing all this on a beating heart. And here's what it looks like fluoroscopically as this device is slowly expanded. Again, once we get to the final position, we'll want to pace rapidly right before we let go of it. So we get it mostly into position, and then the operator at the apex of the heart will snug it down into position into the mitral valve. And as we get closer, we'll begin to pace rapidly, and you'll see the heart rate will go up down here. So they begin rapid pacing because they're close. And then you'll see them snug it down right next to the existing valve there, just like that. Looking in tube views to make sure that it's exactly the right place. Our anesthesiologist has to do a great job with the echo to make this happen. And then once we get it exactly where we want it, we finally expand the hooks, and there go the hooks, and there goes the valve. And then we can stop the pacing. So again, the average time to implant from accessing the left ventricle to implanting it is about 10 minutes, believe it or not. So once you get there, there's not much to it. But getting there and doing all the planning, these patients all have careful CT planning ahead of time. So there's a lot that goes into this ahead of time, huge amounts of planning. So this is what the valve looks like fluoroscopically in place. You can see that there's no leakage of contrast backwards. You can see we can look down the middle of it, and you can see what the valve looks like on a chest x-ray or a city fluoroscopy. So again, that's a major advance for us. So on the left is a 3D rendering from a transesophageal echo of a valve that doesn't close properly and therefore is very leaky. And on the right-hand side of that panel is our new prosthetic valve that we just put in. So that's a major advancement. This is what it looks like on CT planning. One of the reasons that we use CT planning is interventional cardiologists are famous for creating diseases. As we solve problems, we create problems. So one of the problems is this has a large profile on the left ventricular outflow tract. So here's the aorta. So you can see if this gets too close to here, we've created an outflow obstruction. And so that's part of our CT planning, is to actually virtually implant the valve on the CT scan ahead of time so we can anticipate all these problems. So you can see that this is not for your community hospital, right? This is very difficult, requires a lot of training, a lot of time, dedication. So this is what we bring to the table to add to your patient's experience. So there's some experience with this valve very early. This is basically the first 50 patients. There's now about 60, 65 patients that have been done in the world. We're part of this trial, and so we're very early into this. This is only available as a clinical trial currently. The usual time course is about 18 months to 2 years before it'll be at the stage of an approval by the FDA. You can see that it's very effective, that these are 95% of these have severe mitral regurgitation and reduced to mild or none in all of them after that valve goes in. So a very effective treatment. We're really looking forward to that. So again, what it involves in terms of the patient: 4-inch incision in the left chest, left lateral chest, general anesthesia performed on a beating heart, and currently we're in clinical trials only. So I'll open that up for questions. We have a small amount of cardiology humor here. That's an aortic valve that looks like a little mouth with eyes on it.